Yeah, hello everybody. I'm glad to see you here in this webinar. Matt just asked me if it's possible to talk a little bit what we are doing in our office, and so I said, hey, yes, it's a really cool idea. And since we are such a small group, we want to do this very interactive. So I prepared a lecture about how I'm using dental monitoring in my office. But I've already seen some of your questions. Hopefully, I can answer them, and otherwise, just type them in, and so we can discuss about this. So I think they are really good questions, and it's lots of things are similar Germany to Czech Republic. Some of them are just slightly different, and we will figure this out. So let's just jump into the topic data-driven orthodontics, and I'm just asking another question: is this really the new standard of care? Short introduction to myself. My name is Philipp Eigenwillig. I studied dentistry at the University of Greifswald at the Baltic Sea, made my fellowship there. I'm in private practice since 2012, and we completely digitized our office in 2014, so at least 12 years of digital experience in orthodontics. So my office is located in the city of Brandenburg. It's right beneath Berlin. And so my topics are, digital ortho, Ornix specialist. I'm a KOL for DM and also for Align technology for the iTero scanner. And together with a colleague, I founded a learning platform, the Dr. Dozzle platform. And for me, I just don't translate. It says not working, not possible. So for me, it's just like everything is possible in our office. So my experience with DM, I'm not talking only about DM today, but I'm also talking about digital workflow and a little bit of workflow or practice organization. How am I doing my organization in the office? And first of all, when I first heard of DM, my experience, I was first very skeptical. So I first heard about dental monitoring in 2018. I went to the AAO in Washington, and it was the first time DM appeared in big there. And I just said, hey, how cool is this? The patient is scanning himself, and I said, okay, I just want to get this, and so I just grabbed this, brought this to Germany. I was one of the first doctors using it, but it was quite challenging at the beginning. I'm coming back to this later, but and now I'm completely rely my completely office on dental monitoring. So we completely switched. We put all patients in, and I just want to share my experience today. But first, before we start with DM, I just want to show you some cool digital gimmicks we are using in our office, which changed quite a lot in over the past years. And one of them is just my favorite baby. It's a 3D face scan. Not many authors are using face scans just because it's we rely on standard photographs, frontal, lateral view. But I was at the exhibition in our annual meeting and just saw these single shot face scanner, and I just bought it, and it was really quite impressive just not to see a frontal view or a lateral view, but to see everything in 3D. And since I'm a techie guy, I always like everything where it's techie, it's blinking, and everything in 3D. So I just grabbed this one. And since then, all my patients go through face scan data. And since then, I had a completely new view on my patients just because I have a complete different view on asymmetrics, for example. So because we are normally mainly focused on what we are seeing. We are focused on the teeth, we're focusing on just on how is one teeth moving, but we do not keep in mind it always has to be functional and it has to rely on to stick to the face. So for me, just face scan is just a real good feature. Oh, I didn't translate it. Sorry for this. It says it's a three-dimensional analysis, and it's heavily looking on asymmetries. And what I'm going to show you is just an aligner case we did. We are also doing a lot of aligners in our office, and it's an extraction case. But you see the midline is shifting quite a lot to the left side, and it always looks good on the computer screen. So that's basically one of the things. Online or in 3D on the computer, everything is looking good. But we have to think about it, and we have to really be aware of this. Is this really true? Is this happening? Do we need this? But especially this patient, do you know when you're using Align technology, you can add face scans using the Invisalign Practice app, for example? So it's just it's for free. You can just make a face scan, and then you see the face with the teeth and with the clean check. So regarding this patient here, you see that it's mandatory. It's absolutely necessary that we correct the midline in the upper arch. So I just want to share you and give you some ideas what is going on right now. Probably you heard of this. Probably you're using this, or I can totally recommend it. And since we are doing all our patients. On our line patients with the face scans, that's really quite impressive. I just want to share you some other topics we're doing in our office. We are strongly using CAD/CAM appliances. So what do you think about next generation appliances? So basically, the old version is just our technician is bending the wires, putting all the resin together, and performing just an removable appliance. But since we have all our tools available with OnyxF, and since we do have the materials, this one is milled. This one is milled out of a round, and it's flexible. So we have this material meanwhile available in Europe, and it is proven by the authorities for used in ortho care. And what we did, we just tried and we just adapted our conventional removable appliance. So this one was one of the first tries you see here. It's a functional appliance to bring the mandible forward. Sorry. But then we started to think, hey, it's looking awful. And why are we doing such strange things? Why are we doing such a bow here? And we were just thinking and asking, hey, that's not necessary. It's just because we had to do this when we are using a labial bow made out of wire. So we completely adapted our thinking, and we completely adapted our kind of way we are doing appliances. So this is our functional appliance today. So it's just kind of like a bionator. So it's a class 2 device. So we bring the mandible forward. We got some elements to hold on the teeth. We have a labial bow over the upper front, and we have the lower front totally covered. So this one is basically our class 2 retention device we are now using in our office routinely. And for just preparing this, we're just using the OnyxF software. Probably most of you are using OnyxF, and it's totally easy because we can just use our templates and then adjust to the teeth we're needing this. We can also add screws if we like. So it's completely free out of the design. We design our appliances, and then we're going to build this. And that's I just want to give you some clues what we can do now for using digital techniques. And the main thing is we can always put all our information and all our treatment options together. So for me, it's not only when today I'm going to treat my patients, it's not only an aligner case, it's not only a braces case, it's not only a removable first phase treatment or whatever. So it's more like a complex case. So we are trying to treat more hybrid than ever before, just because we want to focus on the needs of the patients. And since we have all those tools available, yeah, we can have a completely virtual patient. So this is the surgery planning. We've done an OnXF. So we have the 3D data from the intraoral scan, from the virtual setup. We have our face scan data. We can make our planning out of this. We can yes, calculate how the face is looking after the surgery, and this one is quite reliable. Specifically with this case, since it's a class 2 surgery case, I just asked the patients, this one is a calculated change of the face. I just asked him, just put your mandible forward and we make another face scan, and then we superimpose them, and this was quite accurate. So the mean deviation was 0.5 millimeters on the chin. What differs real between our calculation and the real reality? Yeah. So I just want to give you some input what we can do today with our patients and with our treatment plan, and what techniques we can use. So I talked about the CAD/CAM appliances, the slide before. So we are using for manufacturing our appliances or our surgical splints such a milling system. So we have such a milling system in our office. So it's the smallest one available, and it's completely good for ortho, just because it do not need a separate pressure air system. And you have these milling rounds, and we can make 2 appliances out of 1 round. And what are the many advantages of such CAD/CAM systems? So we have high precision, we have faster production, we have certified materials. Workplace safety is something very common here in Germany right now, just because our technicians do not want to work the whole day in the dust. We have consistent quality and replacement duplicates if something just happened and the appliance is away. And I want to share you some knowledge of my workflow. So for designing such an appliance, it just takes time. So my technician, when she started, she needs 45 minutes to do this. Meanwhile, she's on 22 minutes, but it's let's stay conservative with 45 minutes. Milling consumes time. It's 4 hours, so it's it really takes time, unfortunately. But the milling machine can run once a day and during the night. Polishing and finishing takes 15 minutes. So when you just look at this, it's 1 working hour for a technician. So 1 technician hour just takes an functional appliance, including designing, detailing, and polishing. So we started thinking. So I just want to not share you only some ortho skills, also some practical economic skills. 2 technician hours makes 2 functional appliances. Since 2 appliances fits 1 round, it's just 1 run of the milling machine. So with 4 technician hours, we can produce 4 functional appliances, including design, detailing, polishing. And our technician are not only working, are not only working 4 hours, 4 working hours a day. We have 8 technician hours. So that's also possible. So we can make some more appliance on this. So this is quite compressed, and the reality is more like this, just because our technician, they do not really want to work as hard as our the old dentist stuff. I don't know how it is in the Czech Republic, but we do have a real big problem in finding good staff, and in finding good staff who is willing to work during the day, not only just half of the possible hours. So I think we are running all on the same problems. When you're not billing some appliances, you can also use the 3D printer. So either Keysprint Hard or Clear, or here from SprintRay, Nickel Flex. So these are some of the possible possibilities just to make some appliances. Let's talk a little bit about selective laser melting. So we're using this quite a lot, selective laser melting, just because we have the possibility to have our virtual CAD design. Do you know this case? I just jumped back a little. Everything is finished, your braces are done, and you're waiting on the second molar. And then we always have to decide, okay, release the braces in the mouse and waiting for the second molars, or just put everything out. And what happens? They're coming late, and they're coming in a poor position. And for us, it's like, oh shit. Yeah. I'm totally sure everybody of us has already experienced this. What we are doing in this case, we are designing such a lower lingual arch in OnyxF. We are just adjusting the slot plane here to the target. So we are just making a virtual setup, see where the lower sevens has to be, make a precise planning, and then we can design we can use such a minimal design for making an appliance to correcting the lower sevens. And that's the thing in the mouse. So it just took us 3 appointments. One for placing the appliance. Second appointment, it was just 15 minutes to adjust the ligature here, just because it wasn't possible to tighten it so much. So we always have to change the ligature. So this was the second appointment. And the third appointment was just to remove everything, just because everything was just right in place. And I just want to show you that sometimes it's so easy to work hybrid when you're using digital techniques. Let's talk a little about impacted canines. So for us, we are always using a CBCT scan when we have a patient with impacted canine. I don't know how it's in Czech, if you have a CBCT available, but for me, I think it's really, really important not to see if there are any resorption, but we have to plan our appliance, and we have to plan how the force is going to be applied, in which direction, just to move the impacted canine in its right position. So here is a patient case with a palatally displaced canine. And what we are doing in this kind of manner, we are planning digital design transpalatal bar with a dual slot right on this band on the upper 6, and we are putting in a TMA partial arch wire, and we're using this arch wire just then to bring the impacted canine into its position in the mouth. So what we are doing is we are just placing the transpalatal arch before the surgery. We just put everything in, but not the segmental arch. Then the patient is going and the impacted canine is going to be exposed by the oral surgeon, and the patient is not coming back on the same day, just because most of my colleagues are used to do this. The patient is coming back, it starts hurting again, just because the anesthesia is getting low, and this always disturbs your daily routine in your work office. So what we are doing, the TP transpalatal bar is already placed, and we just schedule the patient 2 or 3 days after the surgery. And then the patient is coming happy, not feeling any pain. We just placing the segmental arch wire and then activate it to bring the canine into the mouth. And that did a lot to our scheduling, just because we do not want any disturbance in our scheduled daily routine. And this is one of the main things or main giveaways out of the lectures. Your holy thing is your scheduling, and I'm talking about DM and dynamic scheduling or appointments on demand later, how this changed my daily office routine. When we are using braces, we bond everything indirectly. I'm not sure how it's done in Czech. Most of my colleagues in Germany do placing directly, but I'm a totally fan of indirect bonding. because we have this fully digital workflow of bracket placement, tray design, bonding. We have the Onyx software. We can place the brackets virtually. We can adjust them. Yes, fairly accurate on the tooth surface. And we see here we have such a heat map, and there you can see how far away is this bracket from the gingiva, from the surface of the tooth. So we adjust everything with this. And what we are doing, we are using the panoramic X-ray on the second screen just to check the roots. And since we are doing this for a couple of years now, we have significantly reduced our rebondings during the treatment. So we make an in-between diagnostics and then performing an X-ray. And when we see, okay, something, the angulation isn't good, then we re-bond the bracket. But since we are doing this in the beginning, we significantly reduced this one, especially on the upper laterals. I just can strongly recommend doing such an indirect bonding. So once the bonding is done, this one goes to my technician, and he's calculating the bonding trace. And these are my data, because in Onyx you can really completely define how the bracket is covered by its bonding tray. So there are a lot of parameters put in here. What we are doing, most of the bonding trays have some side walls, and the bracket is just placed right into this one. We made it slightly different. As you see here, we do not have such side walls. We have a clamp over the bracket. You can just adjust this here. Yeah, just first of this is just a value where you can say how tall this should be over the arch wire plane, and you can totally adjust this one. So it depends which kind of bracket you're using, which kind of material you are using, which kind of printer you have. So you have to play a little bit around. But once you've done this, you have a completely digital workflow, making your bonding trace, and then do this indirect bonding on the patient, which saves a lot of chair time. And that is the second main giveaway. Our main goal is saving chair time, because that's the most expensive one we have in our office, and it's the most stressful one, just because sitting on my desk and making diagnosis, making treatment plan, making a clean check or whatever, or preparing such an indirect bonding, that's what makes me happy. That's my work. But I do not like stress if my staff is not happy, just because their level of tolerance on stress is very, very low. What I did, I made an intraoral scan after doing the indirect bonding, and I compared this one to my initial planning, and this was fairly accurate. So just want to say, most of the colleagues say, hey, I'm really, really fast placing my brackets manually, like the old way. It's totally fine. But when you have multiple doctors, if you have new doctors in your office, this one is a good choice, just to keep your high quality level to all of your treatments, just to keep in mind. So when we are doing indirect bonding, we just take a week in between first intraoral scan, then on Thursday we make the bracelet placement. We print the tray on Monday, insert the brackets on Tuesday, and then bond on Wednesday again. So we always planned a week. You can do this from one day to another, or with 1 day in between. That's totally fine. But for us, we are just workflow thinkers. For us, it's like, keep it easy for all of your staff. Keep it easy for the assistant and the front desk. She knows he's coming on Wednesday, he's get bonded on Wednesday. My technician always knows he has to prepare everything that I can make the bracket placement on Thursday. So we want to keep this yes, as reliable, as easy as it is, we want to have clearly work paths for all of our staff in our office, and that makes our life far more easier. And the benefit of indirect bonding, that's the time we're using for indirect bonding. We have preparation, bonding, this is direct one, then we're placing the archwire and instruction to the patient. And compared to indirect bonding, we just shortened the bonding time. So the real doctor chair side is chair time is significantly reduced, and that gives us the freedom to do other things, to treat our patient, to plan patient, and to do dental monitoring. So we published this one in the EOK. It's German based, so I don't think it's public in Czech Republic, but who wants to read about this? So I haven't talked about DIM yet, just because I want to show you something. We all know digital ortho. We know our diagnostic treatment planning, digital design, IDB, CAD/CAM, aligners, 3D printing. That's everything we are fully control of, just because that's our daily routine. What we do not have any control of is the other part, the patient. And that's the point where treatment monitoring comes in. When we're talking about oral hygiene or tooth eruptions, aligner treatment, braces case, removable appliance, retention, everything we rely on the patient, then we need the monitoring. And why we are doing this? Oh, I didn't translate the headache. Why digital monitoring? What gives this for us? Do we have any benefits? What's for the patient? And do we have any technical aspects? Is it motivation or burden for us? Is it saving or expense for the patient? We will talk about this, and benefits for the treatments. And let's talk a little about how do you schedule your patients? And most of the offices do not offer online scheduling. So back-end scheduling, online booking systems. If you have ever heard a lecture of me 5 years ago, I would say, don't need it. Just because my office is full, I do not need any online booking system. And my first thought was, I only can imagine doing an online booking system for new consultations. But when we just think about it, when do you schedule your doctor appointment? When do you have time to call an office? It's 8 p.m. or whenever you are out of your office. And that's the point. We need a possibility that the patient can book their appointments 24/7. And what happens to your front desk? 30 calls a day, 50 calls a day? Let's stick with 30. That makes 40 days a week, makes 120 calls per week, times 24 weeks makes 5,000 calls a year. If each call at least takes just 5 minutes of a front desk assistant, that makes 420 hours. That's 6.5 working days just for answering the phone. Just for, hi, this is doctor's office. Oh, you need an appointment? Well, let's look. What about Thursday? Just those basic features. And it comes totally time consuming. And what are your patients saying? They're saying, hey, your office is not available just because I tried several times. And your front desk say, hey, the phone does not stop ringing. And appointment booking through patient gives us a lot of advantages. You need a booking system for this, totally sure. But you can define the appointments. You can send them booking verification, an appointment reminder, and informational material. And that's a real good thing, just to remind the patient, hey, you have your appointment. So what we are doing now, we are trying to put all the patients with all their appointments on online booking. So because I do not schedule them in 8 weeks, I just schedule them when the DM system says me, hey, goal is reached. We come to back this later. Let's switch a little bit to the patient's view, because we always think, hey, we need to see the patient. We need to be present as a doctor. And let's look from the patient perspective. What is just a normal appointment, just a checkup. For the patient, it says they need to go to the office, they need to drive, organization, pick up the child, take a parking lot. This, if everything goes perfectly, it takes at least 20 minutes. Then in practice, be at the front desk, waiting room, hey, the checkup, you're looking there and said, hey, cool, everything's fine. Just stick on it. Yeah, and making a new appointment. If everything is on best level, it takes also 20 minutes. And then for the patients, departing from the office, go to the parking lot, shuttle back home, and report to the other parent what had happened today. So we have to keep in mind that the patient journey is significantly longer than the office appointment. So, and just one question. Do you really think your patients like you? And do you really think, probably they do, yeah, but do you really think they love to come to the office? They want to see you? No, they have other things to do. They want to go shopping, they want to go to the gym, they want to go meet friends or whatever. Have you ever looked at your Google reviews? How many of them say, hey, great team, great workflow, great experience? Yeah, okay. How many of them say, hey, this handsome doctor is really good. I come to the office just because I want to see him. And keep this in mind, for the patient, it's far more easy if they have less appointments too, and they will love it. But I know, and that's what Radim and Matt told me, it's the same like in Germany. You have to see your patient regularly, but our goal is to see them how much we needed to reimburse them, for example, or to bill them, but not any appointment more than is completely needed. And here is where dental monitoring plays a great role, just because in between we need to check our patient and we need to see how this treatment is going on. So since I know you are already dental monitoring users, I can switch the next slides a little bit faster. You know, we have the dashboard, you know, you have for the patient, it's the dental monitoring app. What we are telling all the patients is that they get this video of their ongoing treatment. So they love this video. We always stick on this and say, hey, and you can see the video. Have you seen your video? They loved it. So just to give them a hint. So this is a video of dental monitoring, how the scan box is used. You know all this. There's often a question. The question is how to introduce the scan box to the patients. Do you use it, or do you show the patient how to scan? That's a really good question. 2 or 3 years ago, I always said, hey, it's a good idea to show the patient to perform the first scan within the office. Just to make clear that they're totally aware of, they can scan themselves and they know what to do. And some of my colleagues always keep telling this, that it's completely necessary to perform the scan. What we are doing, since we have, I just told you, we do indirect bonding. So we have an appointment 1 week before we bond the brackets. We hand out the scan box on this appointment before and say, hey, it's completely self-explaining. Their videos inside the app just to train you how to use it. And we just hand it them, motivate them, find your own way, and then we discuss the next time. So this saves us a lot of time, just because 1 week later, nearly 80% of the patients came and say, hey, works fine. And then say, okay, let's start. And the other 20%, they just have a question. And so we are answering just the question. So this saves a lot of time, just to see, to give the responsibility for making good scan to the patient. So I just talked a little bit about my journey earlier. 2018, I went to Washington, and there I first met DM. I first met Philipp Salah, and I was so super impressed. I said, hey, I had to do this. I brought this to Germany, and I made my first aligner cases, and it was bad. I stopped it. It was, for me, I said the product was bad. It was only aligners only back in these days. You have to take in account of this. But today, I know probably it wasn't so it was not good as it is today, really. But probably in 2018, my aligner treatments weren't so good like I do today. So on my perspective, point of view now, I know maybe it's half of the fault of DM back in these days and half of my poor aligner experience, which makes me saying I stopped it. I stopped it completely. And then COVID hit. And I said, hey, the patient could not come to the office. And I had the system. Just remember, 2 years ago, I had this one. And I sent over these scan boxes to the patient and started treating the aligner cases. And then I realized, hey, it's improving, it's getting better. And what then happened, because of the protocol, we do not have so many aligner cases which go off track just because the system sticks them there and put them on hold if it's not working and we come into the office. So I decided, okay, all aligner patients all in. And then I said, hey, in these days, I had 20% of aligner cases in my office and 80% braces cases. I have a good system, and I'm using this only for 20% of my patients. That doesn't make sense. Not at all. So I decided to go all in, to go all in with the braces and to go all in with removable appliances. So I put my whole office into DM, and since then, the scans are growing. The DMC has more work to do, and I see quite a good impact on how to treat my patients and how many appointments I do have. Because we have to keep in mind what we are dealing with. We are dealing with millennials and Gen Z. They're digital natives. They want to be more convenient, be connected, interact with healthcare. And the treatments are less time consuming. The bad thing is you have only 30 seconds to get their attendance. Yeah, it's like a TikTok. Yeah. They forget everything as soon as they're out of your office, probably out of your treatment room. So using the AM just links us to the patient, and that's really, really good. So you know the workflow, the patient is scanning himself, we have the raw scan, tooth identification, segmentation, and observation. So for the whole workflow, a lot of that is done by the AI. Oh, I have to translate it for you. So oral hygiene, aligner fitting, attachment and braces loss. If there's a clip openers and self-ligating bracket, if the arch wire is passive, class 1 is achieved. So these are things which is done by the AI. My DMC's work is to take care of the patients, to start the observation, the put on every patient into their account, controlling the AI messages. All the communication goes to my DMC, and she just gave me some of them where she needs a clinical decision whether the patient should come in or not. So my work is just to control the patients that my DMC is giving me, and then to decide the next steps on the treatment. So you all know the protocols. First, we just using, hey, is the appliance good? Is the bracket okay? We are now relying far more on goals. We talk on this later. You have braces parameters, oral health, intraoral examination. Yeah, you see on the goals in all the dimensions or general goals which are achieved. Yeah, if the patient is wearing class 2 elastics, you can say or you can program this software, geez, please notify me if a class 1 is achieved, or if overbite is normal. Yeah, we're coming from a deep bite when we have a normal overbite or overjet or an open bite. You all know this. There's one big issue right now at the moment. I have to tell you, the system is telling you when you achieve a normal overbite. You see this as a goal, but be aware of the system does not yet does not yet tell you when you're losing such a goal. So if a bite is opening, you do not get any alert right now at the moment. I know they are working on this case, just because technically when you reach a goal, you get a message and then you have an event. When you lose something, you do not have any goal you reach. So it's kind of strange, but they're working on this. But keep this in mind. So you have to look at the patient regularly. And that is what we are doing. We are putting all of our patients on virtual appointments, which means that our DMC is not only looking all the messages which are coming in, she's also looking, are there anything specific? So we put the patients on on a specific time frame with the aligner cases. We do this every 8 to 10 weeks. That's not only the DMC with aligner cases, is a doctor is looking on the case, just to routinely check up everything's fine, yes or no, even if there's a message or not. And that gives us the clue to do these virtual appointments, just to keep on track that always the dog has an eye on this. And also with specific cases on braces, there my DMC is looking, and if something is unusual, so she's really well trained, that's why I can give it in her hands, then she's coming to me and say, hey, what about this one? Let's look at this one. And that's a good workflow with this. So I always got the question, DM with removable appliances. So this one is a case with a bite opening. Yeah, and so it's a functional appliance for treatment a deep bite, and that's what we are seeing. And we see that we achieved a goal after 12 weeks. I know this is a special case. This one is the one good showing case on webinars. Yes, you're totally right. But you can see if the patient is wearing their removable appliances, because you see the what's happening with the bite. And there's one thing, and it was one of the questions you gave me. What do we do when the patient has an inconsistent bite? So he's not really closing, whatever. Yeah, this might happen, but normally you see this when you compare some pictures. Yeah, when you see he's always biting at the same point, then you see, okay, it should be clinical correct. If you once have a bite on the left side, then on the right side, then you know, okay, there's something weird, strange, there's something weird. The patient has not showed you the right position. So then you have to go to check this one in office. And that comes me to the next thing. There are patients, 1 of 100, who can show you every bite you want. And I experienced myself. I have a patient, and he said, okay, normal overbite class 1, everything's fine. We can remove the fixed appliances. And over 2 or 3 appointments, always got overjet from 2 millimeters, 2 millimeters, 2 millimeters. Everything's fine. And I said, hey, the appliance can go out. And I talked to the mother, and on my left eye, I see, okay, he's smiling, closing, and I see, hey, what's that? It was an overjet of 7 millimeters right now. And I looked at him and said, hey, what did you do? And he tricked me. He tricked me clinically. In my office, he tricked me 4 times. And that's what I'm not telling this story just because this one is a good trigger. No, it was just like, if you have a patient who is able to trick you in your office, then he will fool the software as well. And you have to keep in mind of this. But these are just a few, and we are talking about 98% of the others. And that's totally important to guidance. And if you see that a patient does not have a real bite, then he gets instruction by my DMC. She's writing, hey, just keep in mind, when you close the bite, take the tongue to the palate and then close as far on the back as you can. And then we got our real scans. So that's the trick, working with my DMC, just a message to inform the patient, just do it better. Okay, oral hygiene, soft tissue, you all know this, what the protocols can look at, but these are the patients. This is the reality. But I do not see this patient so often. Why? Because of the patients are knowing that they are controlled by the software or by us. And this one, 10 years ago, nearly, I would say 80% of my patients were looking like this. Now it's maybe 10% of the braces cases. And that's, I just want to show you for the patient and for the parents of the patient, this one is the main key feature for using DM. That you say, we have a look at the oral hygiene. And for us, it's oral hygiene is like, oh, I want to treat, I want to do ortho things. Yeah, but for the patients, it's high level importance to have a look, that someone has a look at the oral hygiene. When we look at aligners, yeah, we see aligner fitting, attachment, auxiliary, oral hygiene. So normal change interval is 7 days. When you look in the literature, you see scientific line change typically 14 days, 7 days, just because the literature sometimes are a little bit older. And we all know that the switching to 7-day protocol is just about 10 years old. And before that, it was always 14 days. And we know, for aligners, scan every 7 days, no-go, rescan after 3 days if there's a misfit. And this no-go system takes a lot of cases right on track, just because my experience without monitoring before was like, hey, patient was in the office, everything's fine. 8 weeks or 10 weeks later, I just looked and nothing fits anymore, just because the lateral does not move. And then you decide, okay, make additional aligners or not, or whatever, and or put a button on this and a rubber band, and just to try to refit this into the aligner. So since we have this go-no-go system, it's far more better. I don't know how many of you are using dynamic aligner change. Have you heard of this? Yeah, dynamic aligner change. Normally we start every 7 days. After 3 goes, this one can be shortened to the minimum of 4 or 5 days. I programmed my system. So if you have a patient who's highly motivated, who's wearing their aligners, and the movement is not so complicated, they can change every 6 days or every 5 days. If you have a teenager who's a rebellion, who does not want anything, and he's not wearing their aligners so good, yeah, after 3 no-goes, it is extended by 1 day. So we have the maximum of 10 days. So 5 days change, 10 days change. It's halving of the treatment time if the patient is motivated. And that's what I keep telling the teenagers. Hey, it's in your hand how long you need to go or you wear your aligners. And these are typically day changes. First phase aligner, so we're on Invisalign, I told you, normally we start with 7 days, but most of my patients are running on 5-day aligner change. Teenagers, it differs. Mean stays with 7 days, 6 till 8 days average. What we are doing when we have mandible advancement, we program no dynamic aligner change, just because when you have bite wings or blocks, something like this, the patient, we do not have any other movements on the arch wire. And then I realized first, okay, I was on dynamic change. And since there was no movement in the arch, the system always say, hey, it was good, you can change. But I was running out of aligners, just because on this MA phase, the patient were changing every 5 days. So keep in mind, if you have mandibular advancements, just deactivate these dynamic aligner change. And adults, it depends. So we start with 7 days, most stick to 7 days, so that's normally fine. But this is the reality in my office now. And when you see aligner treatments, so a couple of years ago, I would never ever done extraction cases with aligners. Just let's see at this. Yeah, the canine is on track, but when you see on the DM, sometimes it happens that no change, no change. Okay, now it's fine. Yeah, you can change. So using the DM system here gives me the possibility to make treatments which I would never have done before with aligners. And that's the main big feature clinically, to have these treatments and not to have such a huge amount of additional aligners. And this one is the case. I just want to show you, last summer, this one was bonded, and I've seen them back. I just show you the thing. I saw this patient. It was bonded in July, and on an appointment on November, there was a button loss. And what we are doing right now, we make an attachment bonding, then we make virtual dental monitoring controls by a doctor. So we put it really on the schedule. The patient does not see this appointment. It's just for us as a reminder. Looks at the doctor. If everything's fine, good. Sometimes me or my fellow just writing a message. Hey, Clara, everything's fine. Just stick on this. Yeah, you're right on track. We are doing video messages. Yeah, after a certain time, each patient gets at least one video message out of us. So we just put on in front of the camera and say, hey, you see my lovely face, and say, hey, Thomas, your treatment is very, very good. Just keep on it. Yeah, remember wearing your rubber bands, especially on the left side, and then everything's fine. Yeah, so giving the patient these kind of new care or new quality of care is a pretty high level, and it is completely different than what all the other authors do. So back to the case. We have one button loss and virtual appointments after that. So in 24 weeks, in 6 months, we have 2 appointments, which one of them was a problem. And I said, hey, that's really, really cool, because conventionally, I would, what time consuming this? We take 60 minutes for bonding, 2 minutes each virtual appointment control. Yeah. Then the button loss, it was a 50-minute appointment. So we had 69 minutes of work time within 26 weeks. So conventional, what would I have done before? Attachment bonding and then Invisalign control after 8 weeks, after 8 weeks. The problem would still be the same, and in-office control. And within 6 months, I would have been 5 appointments compared to my prior DM era in my office. And what I'm going to show you is that this one takes 120 minutes of work time. And if we just compare this one, yeah, 120 of work time conventional, 79 minutes work time DM supported, that makes 45 minutes saved each case within 6 months. That makes 41 minutes saved, makes within 12 months 82 minutes saved. And if you're doing 100 aligner cases, saving 82 minutes, that makes 8,200 minutes office time, which is at least 136 hours. And now we start thinking, hey, each time if you have an unnecessary appointment, it costs us money. You have to stop thinking, hey, the chair's available, the stuff is available, we don't care, come in. No, it's costing you money just because the stuff and the chair could not do anything other. And always keep in mind, I know that you have to see the patient regularly, also the aligner cases, but as you see, I saw the patient within 6 months 2 times. And you can extend it. You do not need the patient to see every 12 weeks. You can see them in July and in November, for example. So depending on the phase they are going on. If they are on braces and wearing rubber bands, you do not see them every 12 weeks. You can extend this, but you have to see them quarterly, I think. Yeah. When we look at braces, so this is a braces case, and the patient I told before, they love the video feature, and that's the treatment I learned from Guido Sampermans. He just told me, when I was doing my fellowship, the old school says, never put in within ectopic canine an arch wire. You have to do sequential arch wires. You have to be careful, look on the lateral that there's no side effects on this. Hey, but look, yeah, so what happens here? You have a look every week. You can prove that there are no side effects. And with such an ectopic canine, yeah, you want to, I don't know, you want to put it on the right place. We are using, all of our patients are using self-ligating braces, and we're using here 0.014 initial oil. What is going? What happens? The space opening happens due to binding and notching on the bracket slot, and the arch wire is extended. So that works all the time. So I've learned this 15 years ago, and it works all the time. Till this patient came in. Nearly same protocol, ectopic canine. Here, the upper right one. And we didn't bond it initially. We just did this, at the second appointment 6 weeks later. And what we see, hey, what's going on here? It's getting completely worse. The canine is not coming down. It's coming, all the rest is coming up. And I've never seen this before. And I see this every week. And this happens within 6 weeks. So normal arch wire change protocol, most of the authors say, I want to see every 8 weeks. So my normal protocol is seen every 8 weeks. So here I see after 6 weeks, I decide, hey, it goes off track. Put this on hold. We need to see the patient as soon as possible. And what did we do? We just removed the bracket on the canine, and then we tried to decompensate and try to close the bite itself. And it took us at least 6 months to regain or to come to to a good position where we can go further on. That's a point where DM saved my ass, just because what would have happened if I have seen this patient 4 weeks later or not? And the funniest thing is, look at this canine. This damn shit canine is coming down on its own. And I asked some professors, what happened with this case? And he said, and some of them said, hey, yeah, it was not moving. Probably it was blocking themselves, whatever. So no one could give me a right answer. And that was so funny, just because first I looked on the pictures Radim gave me. There was a case where the system says, hey, it was passive. The arch wire was passive, but it does not look passive. It might be, just thinking on this case, it might be that that it was so how should I say? I try to translate in English. You know, in architecture, when you're building up on churches such a bow, they always put the bricks in, and they are blocking themselves due to their own weight. Okay. Just imagine if we have this here on in March, this case, that all the teeth are not coming down just because they're blocking themselves within the arch wire and are not capable of move anywhere around. Probably, normally the front should protrude, but it's not possible just because it hits the lower front in this specific case, and that's why everything come to hold. I'm not sure if this is right. I'm not sure if this is the right explanation on this case or on the picture you showed me, but I want to show you, I want to just, this one teaches me something. My DMC just came to me, because our daily routine is after bonding, 3 weeks after bonding, the DMC is looking specific on each bonded case, and then regularly, as I told you before. And she realized, hey, that's not looking normal. She came to me and I say, you're right, that's not looking normal. And these are our workflows in our back office workflows just to identify if DM is not warning us, just because, shame on DM, but it's impossible for them. They do not give us a warning that, hey, there was a bite opening. But I know they're working on this. So what will we reach here? We reach a maximum quality of care. And that's what all we want with our patients. Next case. It's on fine. It's from a colleague. Same situation. The lateral is going a little bit up. Yeah, is this a problem? No. Yeah, probably. Maybe you should not use any rubber bands on this, just because these are blocking the movement. Yeah, probably steel ligatures would be better. But what sees the system? Ligature. Here, loss of ligature on the lower lateral. And just to be honest, if you just have 30 seconds, just look in the mouse, everything's fine, yeah, okay, it sucks, everything's fine, yeah, good. Do you always see if such a ligature is lost? The system does, and that's how it helps us, just because you bring the patient in, make the ligature, and everything's fine, and the tooth is not moving away, no round tripping, no extra spare time. Self-ligating braces. It might happen. I know no one wants to have this, but it happens that there's an open clip. Here, a clip is open. What are we doing? We are writing a message. Hello. We realize that the clip is open. Please take a look at the picture, and you can close it with your fingernail. Just put the arch wire into the slot and then close it. If you have any questions, your parents might help you, or if you have any questions, please come into the office and then we take care of it. That was the message. And it says, please give feedback. You will never ever really get any feedback out of this. Remember, Gen Z. But you see the scan of the next week, and then it says, hey, everything's fine. When we compare such an open clip, in-office appointment takes you at least 15 minutes. Registration, waiting room. The real closing of the clip is 2 seconds. Documentation and cleaning of the room. You need 15 minutes for a 2-second work. It doesn't make sense. When you use DM for this, you have brace monitor, identification, messaging, 1 minute. And now let's just assume that it's possible to save just 2 appointments times 50 minutes. So at least 30 minutes of work time with each braces case. Not so many as in aligners, such here, open clip or whatever. So we're doing 200 braces cases per year times 30 minutes. That takes us 6,000 minutes. This is 100 hours of working time. Since we have more braces cases than aligner cases, then just a small amount of time saving has a huge effect or an impact on the whole week, or on the whole year. And that's what we have to think about it. Yeah, here alarm if you have a recession, or here bracket loss. What normally happens when a bracket is lost? Either the patient calls the office, one possibility. Second possibility, your DMC sees this, calls the patient, bring him to the office. I'm going to show you what we are going to do. DM is recognizing, hey, bracket loss. Okay, he gets a message. Here's the booking link to my appointment system. It looks for emergency bookings. The patient can choose, fill in their credentials, and then just hit on book the appointment. They have a security code sending via email, and then the appointment is booked. So no stuff involved in this feature or in this use case. So DM is identifying the bracket loss. The patient books his system himself. And what is the real good thing, cool feature? My booking system is so the preferences in my booking system are like emergency appointments with bracket loss only between 1 p.m. and 3 p.m. I don't want to have those patients at 5 p.m. I want to be ready. I want to have these special time for my aligner cases. So when the patient's calling, oh no, do you have any later appointment? Oh no, on Monday, no, that's not good. He has sport on this. What about Thursday? No, I take then either back Monday. If you give the patient the choice, choose Monday, Tuesday, or Wednesday or Thursday with separate times. The patient itself can say, sport, gym, okay, I can switch this. I can no, I don't go to the grocery, then I can take this appointment, I do this. So, and that's far more easy. It's the patient's work and it saves time. And that's why such appointments on demand are the best thing which could ever happen to your office. But you have to have a booking system where you can have such a appointment booking link for each specific appointment. And that leads me to one big favorite thing. It's appointments on demand. Preparing a lecture last year. The lecture was on November 2025, and I looked 1 year back, 2024, on Monday. And that was my typically Monday. 4 chairs, the 5 chairs. I have 5 chairs, but I only have stuff for 4 chairs. So
Can I ask you? I have just a question.
Yeah, sure.
About the situation when the patient should make the appointment. Do you have like a check that the patient really do this? Because sometimes we had a problem that we write them call to the reception to have appointment, but they didn't do that and we didn't know that. So do you have like a check system for this? Thank you very much.
So that's right, the point, because we do not have any backlink. So we do not see if the patient really books the appointment just because we have the DM system and our booking system. What we are doing, what we are using, if it's done automatically by DM, my DMCs just see this message, and or if she triggers the message because she sees or whatever, then she puts in a label which says appointment ? And so she has a list where she can look, okay, these patients should have be an appointment, and then she double checks. It's unfortunately, it's not automatically right at the moment available. I know that DM is working on integration with PMS systems, but it's always depending not only on DM, also on the PMS system. And sometimes it takes a little bit of time till this integration works. So we are using right now the labels done by my DMC, appointment ? Just to see if the patient has an appointment. Yeah. So
okay, thank you very much.
yeah, it's just a hack. It's just a workaround. Yeah. So this was my calendar 2024 on Monday. Yeah. So completely booked. Okay, let's look at Tuesday. So remember, it was like 1 year before. Tuesday, completely fully booked. And what is the thinking of appointments on demand? The thing is, the patient is reaching a goal or any other condition or whatever happens, and then he gets a booking link after the goal is reached. So we are using passive archwire, for example. If we see the archwire is passive, and then he gets booking. It might be after 6 weeks, after 8 weeks, or after 10 weeks, whatever. What we are using always the 10 weeks feature, because you can receive a message if the goal is reached, and you receive a message at week 10 when the goal is not reached. You can completely customize this, and that's our feature we're using here. And the thing is, we want all our patients on appointments on demand. And I just want to show you this patient. In last year, there was the DM meeting in Paris, the EU summit, and some colleagues from Poland and Spain said, "Hey, we do not see our patient. We give all the aligners away. Now we are on aligners. They give all the aligners to the patient and just make their virtual appointments." And I say, "Hey, but you have to see the patient." And then they ask me the question, "Why?" And I said, "Yeah, but yeah, why?" So just to see this one. November 2024, bonding. January, my normal control in office. Then the EU summit was in April. So I had already had a scheduled appointment in May. So it was already scheduled. So the patient came in, and then I told to the patient, hey, you're wearing so good. We will have a look after in DM after you, and we do not schedule any appointment anymore. And I just want to show you, I haven't seen this patient till January 2026. And I made 2 virtual appointments within between just to see if the treatment is completely on track. I know you have to see the patient every quarter, but you can make this, you can shorten this. You can make every 12 weeks, or if you're in such a phase, you can make like here, like I said before, for example, July and then December or whatever, so you can extend this one. And since the patient is wearing the aligners very good, you go into the office, say, hey, Carlo, everything's fine. Yeah, look, okay, great. Just make a 2-minute show and everything's fine. Because you know that the patient is doing quite well. So what I did, this was my calendar in November 2025. I prepared the lecture on Wednesday, and I had a look on next Monday. So next week, Monday, and I say, see, okay, there were 8 available appointments because they weren't booked yet. I said, okay, let's look on next Tuesday. 9 available appointments. And when I look at my scheduling and my booking system for next Monday, so in 2 days, I know that nearly 25% of my available slots are still available. And I'm not worried about it, just because I know that these on Monday, these slots will be filled up, because most of my patients are on appointments on demand, and they will book these appointments over the weekend. And I just make an animation just to understand this. So the patients receive their message, they should book an appointment. Okay, then it might happen that someone says, hey, I have an exam at school or sports or whatever. I need some space. I need to postpone any of those treatments. So you got still available slots. And if then an emergency happens, this free slot is still available then. And I was afraid of, because my booking calendar once was completely blocked out for 8 weeks. And I said, hey, what happens if a patient is now looking for a free appointment? He gets this appointment only in 8 weeks. And then a colleague of mine said, hey, you stupid, start thinking. Today, your working routine is, if you're on a routinely 8-week change, you say, this week is completely booked, and every patient from this Monday will get an appointment in 8 weeks on Monday again, just because your front desk staff likes to keep things simple. They just book, they just schedule the same patient at the same line on this day. And that's why it happens. You have a shitty day with a lot of impacted canines, and you have this in 8 weeks or in 4 weeks or 6 weeks or whatever you do again. Okay, when you stop tomorrow, or if you stop next Monday, not giving any appointment, then what would happen? Week 2, 3, 4, 5, 6, 7 will be completely blocked out, and week 8 will be completely free. So as soon as you start appointments on demand, even if you do not have any change on the interval, you will have available appointments. So don't be afraid of this. This works. You can start this anytime. And I told you, I try to put every patient on appointments on demand. So that's more typically braces case. Leveling and lining, we are starting with 0114 initial alloy, 0180 20 by 20, and then working phase with a stainless steel and TMA. So what golds are we using? In the beginning, we are using arch wire passivity on 10 weeks reporting interval. So that's one we use in leveling and lining phase. So if the arch wire is passive, then the patient gets a booking link for booking the arch wire change appointment. This one is triggered by my DMC. So the DMC receives the message, arch wire is passive, and then she sends the message, please book an arch wire change appointment. We can use this on 0114, 0118. After the 20 by 20 bioactive, we do not set any goal just because we have a fixed in-between diagnostics. So this appointment is then planned 8 weeks after the 20 by 20. And this one is fixed. We perform intraoral scan, x-rays, whatever, to make readjustments, rebond brackets if needed or whatever. So then we are going to the working phase. Now it depends on the case. So if you have any space closure, you can set the goal if the space is closed. If the patient is on class 2 elastics, so you can see class 1 is occlusion is achieved. But what happens if you just have a crowded patient, you have a stainless steel arch wire, and you could not see any goal, or you could not imagine any goal which should be achieved. It just needs this arch wire to apply the torque, just because the torque isn't something that DM could really see, because it's not accurate enough, or the pictures of the patients are not accurate enough to see this or to measure them. Then we are doing a hack. We're just using scheduled messages. So if there's no goal we can see, we just schedule a message after 8 weeks or after 10 weeks or 9 weeks or whatever you like. And then this message say, hey, it's time to change your arch wire. You're wearing well, please book an appointment. So for us, it's just scheduled. It's basically the same as you would schedule the appointment right now from 8 weeks postponed. But the thing is, for the patient, he got the feeling he's on DM, we are looking at him, and after 8 weeks, he receives the message, wow, okay, I can go on, I can book my appointment. That means for the patient, it's the same kind of experience. For us, it's like, okay, I already know I will see him in 8 weeks, but I keep my schedule clean because I want every patient on these demand appointments, and same with the next one. So these are our sequence, our DM workflow sequence for braces cases. I showed you this picture before when we have such an impacted canine using TMA arch wire just to gain force that the tooth can erupt. We can track this control force eruption with DM. When we look at RMEs, rapid maxillary expander, tracking of crossbite, we do a lot of virtual appointments here. So I have a case. It's a young girl, phase 1, and I just have to look. Oh, I'm talking too much, so we have a lot of not so much time left. So now here, unilateral crossbite, we do diagnostics with the Vala ridge, just to see if there's RME needed or not. And we also always rely on this Vala ridge. So we say, okay, here we need RME. We know within an RME we can correct the crossbites in the posterior region. But we can promoting a proper development of the dental arch, and we know from the scientific literature that it's most effective during early mixed dentition, because all the skeletal structures are still developing in this time. So in 2017, Björn Ludwig and I, we designed, or we put our heads together, and then the idea of TAD match was built. So we both worked on this, and Onyx have just programmed the TAD match module just to make a virtual planning for TADs. And I know who of you are using TADs, I just want to show you how easy it is to plan with the Onyx staff. We have your intraoral scan. We match this with the lateral staff. You can also add CBCT, but it's not necessary for normal TADs. Here we have your library. You can say you want to have a pair. You can define these are 6 millimeters away from each other. You can totally customize it and then place the TADs virtually. And this video is real time. So this is a time I use for planning or placing virtual placing TADs. Afterwards, I save this, export this as a new model, and then my technician is going to design the surgical guide. So we know where the TADs are. We can flip or we can add these canals structures. They flip right on the virtual TADs, and then we just design the structure where all the surgical guide is lying on the tooth. And I especially like if it's on the palate as well, because in these early mixed dentition we sometimes have teeth which are moving just because they're going to fall out within the next few weeks or days. And that's why I always like to extend everything, not to make it such a skeletal surgical guide, which are looking quite cleaner, I know, but I think these ones are more reliable and more stable itself. So this is the time we use to design our surgical guide. We can redefine a little bit, and now we just have to say the software that the inner circle, the inner round of this canal should be removed, and now it's going to be calculated, and this is the design of my surgical guide I'm currently using in Onyx F. So we published this 2017, so it's a couple of years ago. What I want to show you, these are the Money Hybrid extender from Benedict Wilmes. We placed with this with the intraoral scan. This one I just bring in like I did regularly, just to see how it's going on. So I make an intraoral scan. We see that the suture is opening and the expansion is working. When we see this in DM, we can put the protocol to 3-day scanning interval, and the patient see how it's opening. And for us, it's like, okay, we can see the goal, and we can see, okay, correcting the crossbite is reached after 20 days. And for us, it's like, okay, we are totally in control. This was my conventional protocol. Insertion, control after 1 week, since they are so small, control after 2 weeks, and then say, hey, just a couple of more of activating the hierarchs, and then last control after 3 weeks, and then each 12-week control. This is my conventional protocol. When doing this DM supported, I start DM scan every 3 days, and I said, hey, it's not necessary. We can save the appointment. Insertion, first physical appointment after 2 weeks. So when the goal is then achieved, we just write a message, okay, please stop now activating the hierarchs, and then scan every 14 days. So that's my current DM supported protocol for mini hybrid hierarchs. And what do we gain out of this? We save 2 appointments. 2 appointments times 15 minutes. That makes 30 minutes each hierarchs case. And we are doing 40 of those cases per year times 30 minutes. You know me, makes 1,200 minutes, makes 20 hours of work time, which we can save here just using DM for our hierarchs cases. And these are the really, really cool benefits. And if we have surgical case, here it's an adult case, we can always check, okay, is it opening? Is it opening symmetrically or asymmetrically? And we can see how the gap, the diastema is closing again. So we are far more in control and in charge of our patient. And we know that the system can track, and these are old views, it can track where the tooth is moving and which tooth is moving at which time in which direction. Here's a teenager case with a crossbite, and I'm just doing it a little bit faster because it's just a crossbite case. What I'm going to show you, we are planning our Hyrax in Onyx Have. We are planning not only the TEDs, also the Hyrax. Then we get this to a lab where they just may do the SLM print, and we put in the screw and laser mount this. And for the designing thing, it's like we put here some rails so we can just move in the screw. It's not my idea, it's an idea of Oliver Liebel, a good friend of mine, and it was so good, and I love to give the credentials to him. It's really, really good. So what we are doing, we are using our own design for the hybrid Hyrax, and what we're seeing in DM is that we just have the photos and see, okay, it's working, it's very good. And what you see, sometimes the pictures are good, sometimes they are not so good. Yeah, but we see how the whole treatment is going on. And that makes me go to Monitoring Plus. So go to the next level. You heard of it, I've seen it, and I'm using it. It's like, okay, we can see in 3D how everything is going on. You can see how the mandible is shifting back, and you have the possibility that you see what is changing there, but you see that there's just sometimes a little bit of round tripping of the tooth. It's because if we have a scan which is not so accurate, then it's going to be interpolated. So you could not rely on this exact measurements, but you can compare the measurements and see what is going on here. So we can see, you can even set goals on those measurements, and you will receive a message when a specific expansion is achieved, or you can make a superimposition. And that's leads me to the thing, yeah, we have a new standard of care using DM with our patients. And we just have the interactive healthcare. We have oral hygiene. We use it for aligner braces. We have no unplanned SOS appointments just because we have SOS appointments, but they are not unplanned. We know what's happening. Yeah. For my staff, fewer phone calls, no necessary appointments. Yeah. Less stress, proactive management, option for homework. It's possible. Yeah. And we have clearly defined responsibilities. Yeah. And yeah, for me, no necessary appointment, reduced workload, shorter overall treatment time because we have less round tripping, and a satisfied team, and a couple of other things. You can decide, do you want to have less stress, more patients, or higher profits? So it's up to you. For me, it's definitely less stress, what I want, and benefit for the patient. Yeah, the office is always available. We have a closer contact, even though if the patient is not so often in the office, we have a really big closer contact to the patient, and the visualization of the treatment process. This is really, really great feature, and yeah, we are more efficient. So it's like we published this, but I wanted to give you some numbers. If we just save appointments for braces, let's see, 3 overall, for aligners 7, for RMEs 2, and 4 phone calls per year. It's a small office with 140 new case starts. That means a lot of saved appointments over the year, which means at least 16.5 work days and 5.8 work days on the phone. Yeah, so that means 22 work days could be saved just by using DM. Okay, the DMC has to work too, so she needs some time, 2 hours a week for these days. So at least we can save 11 work days in such a small office. And now let's have a bigger office. So it's 300 new case starts, same calculation, which leads to the DMC needs more time to spend on this, but this leads to 31 work days, which could be saved on just by using dental monitoring. I just want to show you something which is not so popular, not so common. It's Engage. I'm using this on my office. So on my website, you can, if you're a new patient, you go to virtual consultation, and then we have just explained the Engage, and this is an avatar of me. I'm come to back this in a couple of minutes. An avatar of me which tells you how to use this virtual consultation. And what you gain of this, the patient makes photos without any scan box, just photos of the teeth like this, and we get a report out of this. And it's not so accurate, but these are the quality of pictures you get, but you still get a clue what is happening with the patient. And then you can say, hey, okay, we got these findings. You can see, okay, there's a crowding, whatever, and the patient gets a report. So you can generate the report and give a suggestion of treatment options, like this one is for aligners, for example. How are they functioning? How they are working? And for me, I also provide some costs on the aligner just to see, just to give the patient the option to choose. I have something for braces, and leave a comment on this that they book their appointment. And what I'm doing, that I'm just offering different first consultation appointments for aligner therapy, for braces therapy, or for functionals for small kids. And so I can, I can define when I want to see which patients. So I can define that aligner care patients gets the appointment far earlier than the normal braces one. And so I'm pretty good at controlling my office. So it's just a clue. Just ask Radim or how this will work if you're interested in Engage. So it's a really, really good thing. And last thing, and then I'm ready, I'm done for today, is AI support and documentation. So our problem is we do not have enough trained staff. Yeah, we have a lot of documentation. I thought we try to use AI documentation like Noah or Sonic. There are different systems available just because we are running out of staff in our office. And that's why we said, okay, we do not have the manpower, but we need to take care of our patients. And a lot of time goes on if we have the problem that we try to explain how the braces work, how the aligners work, how oral hygiene works. And that's why we made our avatars.
Píchají ty fixní rovnátka? To se může stát, například když se mírně posune konec drátku. Žádné obavy. Tam můžeš udělat pár věcí, abys to místo sklidnil. Zkus nejprve drátek opatrně zatlačit zpět směrem k tubu pomocí čisté vatové tyčinky nebo nechtu. Použij také ochranný vosk, který si od nás dostal. Kousek vosku v prstech rozmačkej do měka a přitlač ho přímo na píchající místo, aby byla tvoje sliznice chráněna. Pokud zrovna nemáš vosk po ruce, může ti krátkodobě pomoci žvíkačka bez cukru, než se vrátíš domů. Velmi důležité. Poté se nám ozve přes náš pacientský portál a sjednej si termín, abychom mohli drátek správně upravit.
And believe me, I do not have any idea how to speak Czech. Yeah, so we created an avatar of me, a voice clone, and we are using these avatar videos for explanation, for training the patient, just to give them to answer basic questions. And you can use this on DM. There's a media library. So if the patient gets class 2 elastics, just put in the class 2 elastics video, and then your avatar is explaining the patient and the mother and the parents how these class 2 elastics are used. So this is a complete new feature, and it's multi-language, and I've never talked any of this words before. So this is a German version. It's exactly the same, just in Germany. So we are creating these avatars fully customized. We have over 40 ready-made scripts, information on our website. There you can one can choose which scripts you want, or you can use your completely or your own scripts, and then everything is prepared and if you like, in multi-language, for example, English and tech. And yeah, it saves a lot of time in our office since we are using these avatars for explanation and training of our staff and our patients. I think I'm done with all. We can talk about dental monitoring insights, but since I've talked a lot now, I think, are there any questions, any other questions, or did I talk too long? I'm not sure.
Oh. Carolina, you have raised hands, so is it just by accident or by purpose?
No. I really have a question.
Yeah.
If you have one DMC, it's just one person, or he or she have like a kind of assistant? Because we have for now one DMC, but one assistant. They are switching, and actually even me, I'm doing with our workflow DM sometimes, and I think it's really good because I could see such a lot of things as I would never if I wouldn't like do the routine things. What do you think about this?
So my hint for every new DM starter is you have to do it on your own before delegating to a DMC, because you as a doctor have to know everything. That's first of all. Second thought is do not ever rely on one person. That's really a problem. In my office, I'm actually in this position. I have one DMC, and my trainee is doing the virtual appointments and just ask me if there are any questions. But I'm totally reliable on this, so it's always a good choice to have two DMC, which are where you can change the order. So it said, okay, first responsibility, second responsibility. So having two is always a good choice, because anything could happen, and even if it's just a broken leg or something. But the good thing is, in these days, the DMC does not need to be in the office. It could be done from home office. So good idea is to have two. And what we are doing is each staff in the room, or the treatment room, they are setting the goals, because the docs are aware of okay, define this goal. So we are saying that, but each staff is able to set the goals, and the DMC is just controlling this one. So you need to train your own stuff, but two DMCs is a good choice.
Okay, perfect. And another question: do you have just one account, or every person has the separate account?
I know
in DMC in DM.
Yeah. So we have two accounts, one for the dogs and one for the DMC. We first, when these account structure appeared on DM, we tried once to set a different account for each dog, so you can assign tasks to one specific person. This could work, but on our office, we are still on one doc account and one DMC account, and the person using or sharing this one. I'm not pretty sure if I'm going to switch, maybe, but I know that DM is working on this account structure as well. So right now, just one DMC account and one doctor account.
Okay, perfect. And can I have one question, can I?
Yeah, sure.
When you have some cases when your staff or your DMC needs to discuss with you, do you have any specific system how they ask you? If it's personal, do you have some kind of timed blocks in the calendar, or do you have some to-do list, or how you are make the consultation of the cases?
Yeah, so we have so we try to make everything digitally. So we have for example, for our lab workflow, we have a Kanban board where we put all the stuff in. Actually, these things is done completely not digital. My DMC is coming with a sheet of paper and said we have to look at this patient,
Yeah.
and that's exactly right now. Just because I know if she will put this on the list for me to do, then there's always anything which is more important, and this
Yes.
might get lost. So right now, she's coming with a list. She's not waiting 2 or 3 days till a specially blocked out spot. My goal is that I will have a specially blocked out block where I can see, okay, I just focus on DM, and then we will go on with such lists or assign tasks. But till we reach this goal, I think it's the best. Right now on time, I'm always have to pass by my DMC when I go to the treatment room, and then she asks, "Hey, do you have time later this day? We have to discuss 2 or 3 patients," and then it's yeah, no, yes, whatever. So that's the only completely undigital part in a whole complete digital ecosystem with DM.
Yeah, that's perfect, because our workflow and the history of the workflow was totally the same. And when they did the list for me, it is not so fast. So now it's, doctor, stop, I need you. So that's great that you have it's the same way. Thank you very much.
There's just one thing. What we taught the patients is they can write us, but they do not. They cannot expect an answer within half an hour or whatever. So we're telling them, please write us. They get used to this asymmetric communication, and but you have to tell them at the beginning of the start. And what we are telling them is that please just write really important messages. We always get some messages, all of you did. Hey, sorry, I could not scan. I'm on vacation. I will scan on Sunday. And I was telling the patient this story and say, hey, it's totally nice that you would try to tell us. But this forces us to reply, which just say, yeah, just do so. And so that's why I'm telling this joke to the patient, and all my staff do this before, that we only get really, really important messages. Yeah.
Yes, perfect. Yes, that's the same, because if you have a lot of people on this, that's time consuming. Thank you very much.
Super.
Yeah, sure.
Martina, you have a question. You raised a hand.
Yeah, thank you. I have a question regarding your patients which are not in treatment. I mean, for example, when the patient comes for consultation and you haven't decided for treatment yet, when you start monitoring these patients, I mean, if you can tell us something about your observation protocol.
Yeah, I'm totally honest. I tried everything, but I only have 1 observation or 2 observation monitorings because in my workflow it is like so I do not have so many competitors around me. So we are in our office, we have 70,000 inhabitants and 3 orthodontic offices. So once the patient is in your office, he will always come back to your office. It's so I'm not in need of to want the patient to my office. That's what I'm trying to say, and that's why I'm not in the need of, hey, we need to observe this. Because it's like, okay, you need to see the patient first, then you have to hand over a scan box, and observation, even if it's cheap, it still creates costs. And so that's why I'm relying more on Engage right now. But what I do is I used observation sometimes when I got a first phase treatment, or so it's for the care after a treatment.
Like Hyrax, for example, you showed Hyrax cases when you showed us that you monitor your patients which use Hyrax, and then you stop monitoring them, or you keep going monitoring till the second phase.
So for us, it's when we make such a Hyrax case, it's covered by the insurance, and we got a treatment time of 18 months, so 1.5 years. And what often happens is that then the baby teeth come out. So the phase 2 of the dentition starts, and it's a good point to use this. Actually, I've never thought. So normal use case in my office now is to just to see them after 1.5 years again. So, but I think it's a good idea to go on this observation. Good point.
So basically, you stop seeing them after you finish Hyrax treatment, and then you tell the parents to come in 1 year, or
yeah.
in
So
the
we got
meantime,
1.5 year of treatment. So the Hyrax case. So normally we place a Hyrax, we leave it in place for 6 till 9 months. So
Okay.
we extend those, and afterwards they after 9 months they get a removable appliance normally, or Invisalign First or whatever. If it's in government insured case, we have this Hyrax 6 to 9 months, then removable appliance for another 9 months, and then it is relatively stable, and that's why we can rely on say, okay, we can see this in 1 year again. But definitely observation monitoring would be the better choice. But since we are very using very high the dental monitoring system, I think we are just using 70% of the capabilities which the DM offers to us. So there's a long way to go to have the completely DM practice. But by the way, you just give me some thought. When I have a first consultation, so first contact point is using Engage in my office, but then first consultation in the office, I always perform intraoral scan, even if just for first contact, just for seeing. So I have a look at the patient intraorally, and then I have a look at the scan with the parents and show them everything what's right now in this point. And in this during this first consultation, I tell them, hey, we make everything completely different than all the others. We are doing very digital, but we are not a digital ortho practice which are using monitoring system. We are a monitoring based practice which are very digital. So on first consultation, even though if we do not make any treatment, I'm talking about monitoring the patient over the time, and that's why the patients they know this. And there was a question, what do I do when patients are not scanning? Yes, we do have patients which are not scanning, and they are appearing on the list, and we got an escalation stairs. The first is receive a message, just a group message, hey, please scan. Then they receive a personal message from my DMC, and we tell them on the case start on the beginning, if there's assigned by my DMC, then someone has specifically an eye on him. And what I keep telling the patients, if you receive a message directly from me, it means either you're really good in your job, with your treatment, or you're really bad in your treatment because you're not wearing your appliance or you do not scan. Yeah, so that's why we try to educate the patients just to scan regularly and to come to the checkups. Sorry, it just came to my mind. Yeah.
Well, thank you for your answers. Thank you very much.
And can I have one question, if it's possible?
Yeah, sure.
You were talking about dynamic aligner changing, and it's really interesting. Thank you very much for this. But what if you have like 7-day protocol? It's okay for 3 times, and you switch it to 5 days. And what are you doing when it's like 4, and you need to go back to like 7 days? It's like 6 days, 7 days, and I suppose that you have like a lot of protocols with each like appliance, like 7 days, 6 days, 5 days, or how it's working?
No, it's just the same protocol. It's just the same treatment, same protocol. If they are on aligners, they are really good. They can change, go after 2 goes, or 3 goes, they can go to 6 days or to 5 days. If they are on a phase which is where they do not wear so much, they're going up again automatically, and you can always switch. After 2 no goes, it goes 1 day up.
And it's automatically.
Automatically, but you have to program this. So there's you can go go and no go back. So you have to activate both of them. So it goes back automatically. And what you can always do, you can switch this interval. You can just edit so you're on 5 day, and then you probably the patient is coming in and you see something, or you can always change, go to 7 days back, and then you can switch off in between or reopen this. So it's completely free, easy to use, this system. And what we are seeing, it's always a motivation for the teenagers. Because if they know they could be faster, than their friends in school, it's awesome. Because we really got a better treatment out of this just by using the dynamic change. Something came to my mind while talking. I just forgot. Probably it's coming back. Yeah.
Thank you very much.
Oh yeah, now I know. I completely changed my aligner treatment for this, because what I did regarding IPR, for example, you always got to make IPR on several stages. I always synchronize the IPR on one specific stage, or if it's clinically not acceptable, then on 2 stages. So I don't want to see the patient on week 4, 8, 12, and 16. Then I just synchronize either on beginning, or in this case, I would synchronize everything on aligner 12. And then I put it into the protocol that they receive 1 week before aligner 12 is reached. So when we know IPR to aligner 12, if in protocol, if aligner number 11 is reached, trigger the message, make an aligner IPR appointment, which is already set up by my DMC in the protocol. So we don't have to think about it. Everything's fine. And then aligner 11 is reached. He can change then to aligner 11 and then book an appointment next week for an IPR.
Yes, perfect. Thank you very much.
Yeah.
Good. It seems like we are done, guys. Anybody, any other questions which pop ups on your mind?
Actually, there are a lot of questions coming when using this, when expanding and using all the features. And I just want to say thank you for listening. And the biggest take-home message is appointments on demand is the best thing which ever happens to my office. And I made this change now a year ago, or a year and a half, meanwhile, and it is like, it gives me so much freedom, because just short story, then I'm done, because it's Friday. I forgot the holidays of my kids. So schools off holiday in winter. I do not forgot them. We know, and they're going to after school care during vacation. So we are in our office. But I forgot, because for me it was like a normally daily routine, working till 6 or 7 p.m. And then 2 weeks before the vacation, my wife and I said, "Oh shit, we forgot. We haven't blocked out." We looked in our scheduling and 2 weeks ahead and said, "Hey, okay, 5 patients already in. We can just move them somewhere else. The rest is still free because all of them are on demanding appointment." We decided, our fellow is in the office, but my wife and we decided, okay, in this week we skip, and we were out of the office at 3 p.m. To have some time with our kids, and that's the freedom that I earned out of appointments on demand. And dental monitoring is a tool to get there. Well, thank you very much. If there are any questions, please feel free to contact me. Feel free, go to the Dr. Dozo website if you're interested into the AI avatar. Radim and Matt and I, we discussed whether it's possible to come to my office to Germany and to see how what works in real life and what does not. So if you like. So I wish you a great weekend and yeah, see you. Oh, by the way, I'm got an invitation to the iOS Prague next year. So I'm going to visit Prague next year. And I think, I hope I will see you in Nice in September this year to the Dental Monitoring Summit. So I would happy to see you there in person.
Okay. Thank you very much. It was really nice, Doctor. Thank you.
Thank you so much,
very
Philip.
much for
Thank you for your time.
Thank you.
Sure, thanks.
Bye.